How do things work? Things that give so much joy and happiness. Things of beauty and balance. How does it all come together so perfectly? How can the right support drive optimal health? How can we help manage chronic illness? How can shared intelligence spark brilliant solutions? How can doctors and patients build even stronger relationships? How can we improve the quality of healthcare and make it more affordable? How do we bring everything together so that healthcare works for all of us? We know how. We are the how. Optum. How well gets done. How do things work? Things that give so much joy and happiness. Things of beauty and balance. How does it all come together so perfectly? How can the right support drive optimal health? How can we help manage chronic illness? How can shared intelligence spark brilliant solutions? How can doctors and patients build even stronger relationships? How can we improve the quality of healthcare and make it more affordable? How do we bring everything together so that healthcare works for all of us? We know how. We are the how. Optum. How well gets done.
Good morning. I'm Joy Alampay, Executive Director of Asia Society Philippines, and welcome to our final discussion under Practical Partnerships for the Pandemic. This is a series of online conversations on how the public and private sector in the Philippines can work better together to beat the COVID-19 pandemic, particularly through large scale and fast vaccination. We conclude with a discussion today on the digital dose needed for vaccination, which will surface challenges and lessons, as well as practical solutions to vaccine service delivery and rollout. I am looking forward to listen to our esteemed panel, a well-respected lady senator, a special advisor to the National Task Force Against COVID-19, a tech and innovation expert from the private sector, and friends from Optum who will provide us with evidence-based knowledge and experience from the US. Now, let me call on our partner, United Health Group's Vice President for External Affairs in the Philippines, and an Asia Society Asia 21 Fellow, Attorney Darwin Mariano. Darwin?
Hi, Joy. Good morning to everyone listening and watching us in the Philippines. Good evening to those who may be in the US or other parts of the world that are interested and have taken time to join us today. We're very happy at the partnership with Asia Society Philippines. I think this is part of the United Health Group and Optum's efforts to contribute to really important conversations that are happening in the Philippines. And we want to bring our expertise and contribute to those very, very important conversations, whether it be in the sharing of best practices or lessons that we've learned as a business that has operated as a healthcare organization, one of the largest, particularly in the US. Now, I have to not delay the program any further, I have the honor of introducing our moderator, who is a health systems specialist with a Bachelor of Science in Molecular Biology and Biotechnology and Medicine from the University of the Philippines. He also has a master's degree in Health Systems and Public Policy from the University of Edinburgh in Scotland. He has worked extensively with the World Health Organization and the USAID. Very, very active in many public health issues, but most recently, of course, in pandemic response, particularly around COVID-19. Ladies and gentlemen, let me introduce to you Dr. Albert Domingo.
Thank you, Attorney Darwin and Joy. Welcome again. Good morning to everyone here in the Philippines. Good afternoon, good evening to everyone in the stateside and anywhere else in the globe. I'm so happy to see you here. We are all together again for the third iteration of the Practical Partnerships for Pandemic. This is now about more on lessons on vaccine service delivery and rollout. We have an exciting panel right now, a collection of speakers who are actually experts in their own right and who are very much involved in the day-to-day management, not only in the Philippines, but also elsewhere in the US in particular, of vaccine service delivery and rollout and other aspects of the pandemic response. So allow me to quickly introduce all of them, and then we'll go straight to the conversation we will have this morning. First off, I'd like to introduce Senator Risa Ontiveros. Senator Risa Ontiveros is a health and women's rights advocate, a proud activist, and a champion of the basic sectors. She is the Philippines' first socialist woman senator and is a proud member of the Akbayan Party and is its current national chairperson. In 2001, she received the 10 Outstanding Young Men Award for Peace Advocacy for her work in the peace talks with the National Democratic Front. 4 years later, in 2005, she was one of 27 Filipinas that joined a group of 1,000 women worldwide who were nominated for the Nobel Peace Prize. She also served as a member of the board of directors of the Philippine Health Insurance Corporation, or PhilHealth, and she pushed for expanded benefits and coverage, specifically for indigents and senior citizens. Good morning, Senator Risa.
Good morning, Dr. Albert, and all our other participants.
Thank you, ma'am. Our next speaker in the list is Dr. Teodoro Ted Herbosa. Dr. Herbosa was the Health Undersecretary of the Philippines from 2010 to 2015. One of his important accomplishments during his term was helping achieve universal health coverage or universal health care in the Philippines. He also led the modernization of public hospitals through health facilities enhancement and the public-private partnerships. As CIO, he achieved COVID-5 certification and developed and implemented the National eHealth Strategic Framework Plan. He also served as the coordinator of foreign medical teams that responded after Typhoon Haiyan struck in 2013. Most importantly, for this morning, he is currently the special advisor of the National Task Force Against COVID-19. Good morning, Dr. Herbosa.
Good morning, Albert. Good morning, Senator Risa. And good morning to everyone. Good evening to the guys in the United States.
Thank you, sir. Next on our panel will be Mr. Richard Bon Moya. Richard Bon Moya is a former Undersecretary and CIO of the Department of Budget and Management, Republic of the Philippines. He was a member of the Philippine OGP Steering Committee and part of the Philippine delegation that participated in the launching of the Open Government Partnership. Oh, that's what OGP means. He is currently a Ford Foundation Fellow tasked to assist the OGP Support Unit. And he is currently the National Technology Officer of Microsoft Philippines. Good morning, Mr. Moya.
Good morning, Doc Albert. Magandang umaga po sa inyong lahat. Good morning, Senator Risa. Good morning, Doc Ped. Magandang umaga po sa mga bisita natin ngayong araw.
Thank you, sir. And now let's travel a bit to the east coast of the United States. I'm guessing your location right, Dr. Cobbs. So our next speaker will be Dr. LaShonda Cobbs, who is a retired colonel also. She joined Optum Serve in July 2020 and was appointed the Director of COVID-19 Services. As the Director of COVID-19 Services, Dr. Cobbs is responsible for leading the organization in providing COVID-19 testing operations, later adding COVID vaccines for private and public organizations across the United States. As of March 30th, the organization is responsible for performing more than 4.17, you heard me right, 4.17, wait for it, million COVID tests and over 178,000, wait for it, COVID vaccine shots using approximately 16,000 staff members. Good morning, Dr. Cobbs. Good evening, rather.
Good evening, good morning, Senator. Good morning to you, Dr. Herbosa, Bon. Good morning, everyone. And Dr. Domingo, just one quick correction. We have done over 500,000 vaccinations to date. So we are really.
Oh, wow. That's roughly 400,000 more. My bad, but good for the U.S. And hopefully, let's talk about that, how to get that number here in the Philippines. Right. So next on the panel will be Dr. John Hitt. Dr. John Hitt is the evidence-based medicine implementation sage and senior national medical director for Optum Care. He has been a physician executive for more than 25 years. Most recently, he was the CMO of Ativa Medical, a medical device startup company and an independent healthcare consultant. Previously, he was chief medical officer at Maricopa Integrated Health System, or MIHS. And as the CMO at MIHS, Dr. Hitt was a key member of the senior leadership team, having responsibility for medical staff services, grants and research, academic affairs, risk management, physician contracted services, and he also coordinated the activity of residency program directors, clinical department chairs, and medical staff. Good evening over there, Dr. Hitt.
Thank you all, fellow panelists. Senator, great to see you and meet you. Fellow physicians, Dr. Herbosa and Dr. Domingo, great to see you. Looking forward to a lively discussion. As always, Dr. Cobbs will lead the way. I'm just her support person here. You know, she's got the numbers on the vaccine side. So we're excited to be here.
Great. Welcome, everyone. So let's get straight to it, to the discussion. I'm just really excited. So ladies and gentlemen, you've heard the positions and qualifications of our panelists. So let's begin. Here in the Philippines, it seems that we are in a transition. Just a few weeks or a few months ago, we were saying that there was a scenario of a low supply, right? And now we're seeing, and maybe Dr. Arbosa will be the one who can give us an update on this, sir. So we are seeing a shift from a scenario of low supply to incoming doses from many sources. We wonder what those sources are. We are seeing a lot of numbers being thrown left and right. Let's expect this brand coming in, and so on and so forth. So, and there's also another shift on the demand side. We used to have a situation of very high hesitancy, and now there seems to be some sort of a bandwagon effect developing. We're not saying that it's already like in full force, but we are picking up indications that people are, in millennial speak, having a fear of missing out. FOMO. I want to get that vaccine. FOMO. So, Dr. Arbosa, do you agree with this observation? And what do you foresee are the operational factors that can be improved? Sir, Dr. Arbosa.
Thank you, Albert. Just to give a bigger picture of what it's like in the Philippines, because we only started our vaccination program in March. Our first delivery of vaccines came with 1 million doses from China with Sinovac on February 28th. And immediately on March 1, people got vaccinated. I was one of those in the front line, in the ahead of the queue, being in the Philippine General Hospital, where they started the first vaccinations. Since that time, we now have landed 12 million doses of vaccines in the country in the past 3 months. No, and the largest deliveries, as you did say, had come just last week. We had 4 million doses that arrived last week. 2.2 million from Pfizer, the COVAX facility, another 1.5 million from Sinovac, and then Gamaleya also delivered. And I think tomorrow we also have another delivery of Sinovac that is arriving, another 1 million doses. So the deliveries are coming. We've also started to increase the number of vaccinations. For the past 3 weeks, we've reached 1 million doses per week on an average. We had a low last week because of the decreasing supply and attention to other places that were having outbreaks. So these are the difficulties. To begin with, the strategy of the National Task Force was really a portfolio approach. We are probably one of the few countries that did this. We did contact 7 vaccine suppliers. We identified the top 7 or 8 now, and we got several doses and commitments from them to get a total of about 140 million doses to cover for the 70 million. So we've loaned some money to be able to get some of those. We've used some of our savings. But I think as long as the deliveries come and the people do not become hesitant, luckily there's been a bandwagon, and what we call the real world experience of Sinovac has shown some confidence even among our healthcare workers and Filipinos that Sinovac also works. So which is the bulk of our, I think 4 million of the 12 million had come from the Chinese vaccines. But as the other manufacturers deliver, we will see this. There were some unintended consequences, people starting to choose the vaccine they like. We didn't foresee that when we did the portfolio, but that's a reality. We have OFWs that require the Western-made vaccines because of requirements from other countries. But I do hope that changes with the declaration of the WHO that Sinovac is included in their emergency use listing. So I'll stop there. I talk too much, so I'll give back.
That's okay, sir. That's okay, sir. So it's glad we are glad to hear that there are a lot of doses coming in. Although, of course, as we all know in public health, whether it's herd immunity that we call it or population protection, the whole idea here is reaching a proportion of the population. On the high end, maybe 70 million Filipinos. On the low end, 58 million. And we are seeing from recent data a rough ballpark figure of just 3 million Filipinos thus far, sir. Sir, can you give us like 1, 2, or 3 operational factors from your experience at the national level, but in the operational sense? What's keeping us from going maybe 5% of the population, 5 million Filipinos, in the immediate next few weeks? What do you think needs to be done, sir?
Let me put that in proper perspective. We have over 5 million, as much as 6 million, already partially protected. That means they have the first dose. But we have about 2 million that are fully protected. So that's the full dose of 2 doses of whatever vaccine brand they got. So we've got about 7 million. So I think I think that's higher than the 4% you're quoting. So I think the people who want to paint the perception that we're really slow is saying that. But I think the pace will actually improve. My thinking is that if we get to 50% of the population, about 50 million, and we're targeting the high priority, meaning the A2 and A3, which is really the ones that will contain this illness. So what happens when you vaccinate senior citizens and you vaccinate persons with morbidity is you will decrease the number of people requiring to be hospitalized because you decrease severe illness and death. And that's what we want to happen because our healthcare system, we'll talk about that later, really needs a lot of building. The health system has a lot of gaps, which has surfaced because of this pandemic. So we're trying to do the 50% at least by September. That's the target, and the 70 million by the end of November.
Dr. Urbosa, interesting. You beat me to the segue. So if you had a chance to talk to a member of the Senate live, what would be your request for legislation? What you mentioned that there were gaps highlighted by COVID-19. Maybe the vaccination rollout is highlighting a gap or gaps in the service delivery or in the financing, basically in the health system. If you had a chance to converse with a sitting senator, what would you request should be the policy maybe modification or review that has to be done to help us get more than above 7% of the population in the next maybe a month or two? Of course, we know how legislation works. Sir, what do you think when you ask the senator?
Well, maybe I will remind our senator, especially those in the Health and Demography Committee, that when I was Undersecretary of Health, I had a project on public-private partnership, and the partnership was actually with Serum Institute of India. It's called the Vaccine Self-Sufficiency Project, and it was funded, but apparently the people that replaced us did not continue to fulfill that particular project, and I feel bad because that could have been a very useful fill and finish production plant owned by in a PPP model, and that's exactly what Indonesia has. Indonesia has been able to vaccinate very quickly because they are manufacturing Sinovac in Indonesia, in Jakarta, I think. So they were given a fill and finish because there was a company that was able to do that. If we had established that in 2013, we would be at least fighting this without delay of deliveries. We would be able to get bulk of vaccines and then be able to fill and finish them and distribute them at a faster rate. So I'll still say this is important. This is a priority bill that our senators need to actually legislate and fund to be able to have a vaccine sufficiency system, a vaccine production, and also a virology center or a CDC type. So these are the things I've seen that has surfaced. And I think we need to have a sunset review of the pandemic plan. The IATF MEID needs to be reviewed, but let's review that after the pandemic. Can we request our senators to let them continue their work and then afterwards have a sunset review or an after action review of the efficacy of the Philippine pandemic plan?
Thanks, Dr. Urbosa. And that's my segue to Senator Risa Ontiveros. Ma'am, have these concerns been raised to you? Of course, I understand from Dr. Urbosa's suggestions that these are already medium term to longer term. No? So, ma'am, but on the operational front, have you been receiving suggestions? And can you tell us more? Are there initiatives in the Senate among your staff, your colleagues, on how to probably hasten the delivery in the short term?
Indeed, Dr. Albert, the Senate hasn't been remiss in helping set up a policy framework with all the urgency in the short term in order to equip the executive to swiftly and effectively respond to the pandemic. So we passed the Republic Act number 11525, an act establishing the Coronavirus Disease 2019 Vaccination Program. There's a national COVID-19 roadmap that's a partner to this, and there is the National Deployment and Vaccination Plan for COVID-19 vaccines. Also, during the previous budget hearings, one of the questions I asked of Health Secretary Duque was what the department's plans are for vaccine sufficiency. what Dr. Teddy was talking about, vaccine self-sufficiency. And he's right. We used to have a biological production service that manufactured vaccines here in the Philippines. And indeed, after the pandemic, after we do our review and assessment and proposals about it, I would gladly, and I'm sure I'm not alone among the senators, revisit that service, revisit that program, revive it, and make sure that it's funded annually. Dr. Teddy also mentioned that there are some who are creating a perception that our vaccination rollout is slow. I would gladly plead guilty to that. And I don't think it's a problem to really, and we in the Senate, that's part of our duty to oversee how laws, not just the Republic Act I mentioned, but also the special laws, the Bayanihan laws that we issued with items for health and specifically COVID response. In the exercise of our oversight function, we also look at what are the actually existing conditions on the ground. And I'm glad to share Dr. Teddy's earlier reassurance that the interagency task force or the national task force and the Department of Health itself yesterday in the Senate Committee of the Whole hearing committed that they are ramping up and they will ramp up further in these weeks and in the next months until end of the year 2021. Today, we're averaging about 140,000 vaccinations a day. And so we do expect the incoming doses to meet the target. I confirm what Dr. Teddy said. Right now, we have in our hands about 74, was it? 74, wait, let me go back to my notes of yesterday. 12.7 million doses. And yes, by the end of the year, we will have 148 million. So in principle, that should mean that we could vaccinate at least 6 million Filipinos within the rest of this month, June. And by the end of the year, in principle, be able to vaccinate 70 million total to move towards that early set goal of of herd immunity. Yesterday in the Committee of the Whole hearing, Secretary Galvez of the National Task Force committed that by the third quarter, we will be vaccinating an average of 500,000 Filipinos a year, an estimate earlier raised publicly by Undersecretary Vega, who's also with the National Task Force. And yesterday, Secretary Galvez said that by the fourth quarter, we will be vaccinating 740,000 people a day. So it was reassuring, Dr. Albert, to hear these words from Secretary Galvez and even Health Secretary Duque, because at the beginning of the hearing, none of them were even mentioning the term herd immunity. But on my questioning, they gave the reassurance that that is still the end goal, though they are using, it seems, intermediate strategies right now, like what Dr. Teddy mentioned about population protection. And about hesitancy and confidence. Well, on hesitancy, vaccine hesitancy, the social weather stations, one of our main survey outfits in the Philippines, had said that only 1/3 of our population are willing to be vaccinated, while the other 2/3 are either uncertain or still unwilling. So let's not yet overestimate the hype over the vaccines, especially here in Metro Manila. Some of the more cautious observers would say we may only be seeing the vaccination of the willing. But it's really good to see, at least in our news reports, more Filipinos queuing at the vaccination centers, really anecdotally indicating that vaccine confidence is rising. And the Department of Health must, take this ball and run with it. Really, let's not be complacent. Let's do that broad, massive, accurate, confidence-building information campaign, so that local government units, don't have to resort to raffles. Private companies don't need to offer vaccine benefits. No, so these efforts, very welcome efforts, still reflect the need to continuously build more public confidence and rebuild public confidence in our vaccination program. Let's make it easier. Let's create that enabling environment to make it easier for every Filipino to get vaccinated once he or she decides to do so. And when we called for incentivizing earlier on, we'd hoped it would remove the barriers that hinder voluntary vaccination. And while many local government units have indeed shaved off or removed many of the structural barriers like time, transportation, and queues, our health officials still need to continuously address barriers when it comes to our attitudes about vaccines. So I can't stress enough the communications efforts of the Department of Health about vaccines. And lastly, about this, the reasons for not getting vaccinated may be too personal or localized. So the role of our
Right.
primary healthcare workers is just essential because for some, they are the first genuine point of contact between people and our health system when it comes to frequently asked questions about the vaccines. And lastly, about policy and operational factors. Well, for us in the Senate, there must be no more excuses. No excuses. Budget was actually expedited for this in the past 2 cycles. Targets were set. So naturally, we had expectations, and there were even advanced procurement. And we asked about this in the committee of the whole hearing yesterday. So at that hearing, I also asked for a more detailed breakdown of the money spent on vaccines, disaggregated from the money spent on logistics and
Right.
other ancillary services. So logistics like needles, syringes, disposal, cold chain transport, and last mile delivery. There should be a unified vaccine tracker by now, accessible to all. And for those areas outside Metro Manila where there are surges, a vaccination catch-up plan.
Senator, you mentioned local government units, no? So I think
Yes.
you might have a hint already where I'm going. So one of the excuses or reasons given, whether for or against a good performance, is devolution. So it's always been mentioned that maybe the devolved system is the reason why DOH and the NTF cannot quote unquote command an LGU. But on the other hand, there are also citations that if it were not for devolution, this LGU or that LGU would not be able to pilot innovations. Ma'am, what are your thoughts? Is devolution helping us or hindering us to roll out?
I think devolution is helping us, and but devolution requires certain supports, both to the local government units themselves, and then supportive mechanisms to create those optimal partnerships between local and national government. You're the perfect person to lead us in answering this question, Dr. Albert and Dr. Teddy as well, because we know that years before we passed the Universal Healthcare Law, health sector reform advocates were really calling for an assessment of the implementation of the local government code, which devolved, among others, health as a
Yes.
program to the local government units. But many local government officials complaining that the resources were not proportionately devolved together with the mandates. And therefore, the health sector reform advocates were also observing and lamenting about the unintended consequence of the local government code, that it fragmented our health system. And that's why we all midwifed and gave birth to the Universal Healthcare Law for many reasons, but also to heal that unintended fracturing or fragmentation.
Right.
And it was really a wonderful, I think, follow on many other historic health advocacies, the Alma Ata Declaration, the focus on universal healthcare, the Millennium and Sustainable Development Goals, and now our own universal healthcare system to come up. And even within that law, we already came up with some mechanisms for that local to national partnership, like the setting up of the fund at the provincial and city levels to facilitate amending of the old partnership between the Department of Health and our local government units. Even when the pandemic hit, early on, one of our advocacies was for COVID-ready LGUs or local government units, because we said even after the pandemic, local health governance must be already a learned capacity of the local government units. And now, I'm sure also top of mind for you, Dr. Albert, is the a very interesting situation of Cebu province. Yesterday, within the committee of the whole hearing, of course, points of conflict were aired, but I did see one concrete way forward that was agreed upon, that the National Task Force would sit down with the Cebu Province Provincial Board, have that dialogue between the two of them. And Governor Gwen Garcia said after that dialogue, she would request the provincial board to revisit their provincial ordinance, which I think exercises not just the autonomy of local governments and concern for our overseas Filipino workers, but is an attempt of a provincial government to read their local health situation based on actually Department of Health data. Those were all what Governor Gwen Garcia presented yesterday, and come up with their own localized health protocols based on the national guideline. So moving forward, it's very exciting, although these are terrible times now in the Philippines and all over the world, to learn our lessons about moving forward into a new and hopefully better normal, preparing for other pandemics or other health emergencies and disasters, how to learn the lessons of the local government code, hold up the universal healthcare law as our Magna Carta, as I believe, in my heart and my mind, the mother of all health laws from here on, and see it implemented from national to local levels.
Thank you, Senator. Perfect segue to the next person I'm going to ask. No, you mentioned that there are many lessons to be learned. You mentioned that there is this dynamic between the province of Cebu and many other provinces, and also the national government. It reminds me of in the not so distant past of one of our partners who actually is responsible for a lot of the legal systems and the milieu we are in right now, the United States. And you did mention also international experience. So I'm going to ask now Dr. Cobbs. So Dr. Cobbs, in your experience in the United States, which has a more or less also devolved system, you have the federal government, you have state governments, and then you have a huge private sector, pretty much like a big version of the situation we have now in the Philippines. Dr. Cobbs, in your experience in the US, what have been the prerequisites or factors needed to bridge these very delicate issues that we've heard, as Senator Risa, Dr. Ted Orbosa mentioned, to bridge government and the private sector, government at the federal and at the state level, and also the private sector when it comes to COVID-19 vaccination rollout? What are the secrets? What are the tips, Dr. Cobbs? Fill us in, please. Dr. Cobbs, you're on mute, I think.
Okay.
Right. There you go.
There we go. So thank you so much for the question. And so the bridge, it's always partnership, right? It's one, recognizing and understanding what the demands are. So really you can think about it in terms of 6 things, and that is availability. So, looking government wide, how available our vaccines, and not only vaccines, but Senator, you mentioned this briefly. However, it's extremely important, but how available are the supplies, the supplementary supplies that need to go along with those vaccines? There are special needles to ensure that you maximize the number of doses that are coming from those individual vials and making sure that you have those accessible. But secondly, also making sure that you have the people to be able to administer, the trained staff to be able to understand the requirements for setting up, how to partner with the government, local and federal, how to partner with the different organizations, the subsets that make up those local governments, and recognizing what those subsets of communities need in order to defy some of the hesitancy that may be going on. Every portion of the population is going to need something a little bit different. Some will rely on knowledge, some will rely on trust, some will rely on a demonstration of the trusted folks within their communities, seeing those people receiving the vaccines. And so looking at that, then accessible. making sure that you are able, working very closely, again, because it's got to be about partnership. It can't be about someone coming in, doing something to the community. And so how accessible, making sure you're in the right place at the right time to meet the needs of that specific group of folks. And then acceptable. The community has to be acceptable. The local, federal, the community needs to understand, and they have to be ready. Everybody is going to, and the senator mentioned this earlier, everybody has to be ready, and that's on their own terms and affordable, right? Reducing those barriers. The senator talked about the queuing lines and transportation, but also cost. And so finding ways for the federal government and the local governments to develop different grants and opportunities for vaccines to be made free of charge, and people just need to get to the locations. And now what we're experiencing is us actually going out, meeting people where they are and becoming more mobile, and also communication, right? And so it's got to be internal communication within the federal government, making sure that everyone has an understanding of what that plan needs to be, what the federal plan for delivery is going to be, and then in the different organizations that will be supporting the delivery, making sure that the operators are in line with the strategists, in line with the healthcare professionals. Also ensuring that you are helping to demystify any things that are out there. And then, Dr. Albert, you talked about FOMO, fear of missing out. Reaching those people that are able to have an impact on the population, and so that they don't have that fear. And so those are just some of the things that I think that are hugely important, that we've had to work not only with federal partners, but with state and local partners as well, to make sure we're getting vaccines out.
Thank you, Dr. Cobbs. There's a big word that you mentioned, and this is my segue to Dr. Hitt. So you mentioned about demystifying. Almost every day, there is new information on the safety, the efficacy, which vaccine does what, the very, very often touted vaccine efficacy numbers. Oh, my vaccine is better than yours because mine has 95%, yours is 50%. Dr. Hitt, my question is, in your experience as a practitioner of evidence-based medicine implementation and the clinical sciences, how have you helped demystify all of this information overload? We're not even talking about the infodemic of false information. We're talking about legitimate information being pre-published left and right, which could be affecting the hesitancy that Dr. Urbosa, Senator Risa have been mentioning, which could be affecting the rollout that Dr. Cobbs just mentioned. Dr. Hitt, what are your observations on how to help demystify the complex technical scientific information so that we can roll out more vaccines? Over to you.
Thank you, Albert, for the question. I think it's actually a couple layers of understanding. The first layer is people need to really appreciate the disease COVID-19, right? And in the US, it was largely invisible to the population because the people that got really ill were in the hospital and only healthcare workers saw them. And so for many, particularly younger people, they didn't see this as a problem. And, you know, you have to recognize that the disease is a problem to go get a vaccine for it, right? So it's very important to present science-based information about the severity of the disease and the potential of it being much worse than pandemics with respiratory viruses in the past. So that's job one, really make sure that you can present evidence about the severity of the disease. So one example, and people have to appreciate that we don't really know the risks for why certain individuals may get severe disease. We do know comorbid conditions that put you at higher risk, but take relatively healthy 40-year-old person, we don't understand why one person may have a very severe respiratory course and others may not. So that's the first step. They got to have a burning platform, right? in other words, they're standing in the middle of a fire and they know they got to jump and get their vaccine or burn up on the platform. So we want them to know that this is a severe illness, and even if they don't care, even if they don't care about the illness to them, we want to emphasize how they could spread this disease to their loved ones. So that's very, very important, right? To emphasize that, okay, you may be healthy and you're never going to get sick and you're never going to take, but what about your grandma? What about, somebody at your workplace who may have an immunosuppressed condition? So this science education is really important. And all along the way, we produced information both for the practitioner and also for patients. And we produced information that the physician could use to talk to patients, right? So what do you say when they say, I'm worried about, this? Or, well, I may be trying to get pregnant. What do you, and goodness, when I've done medical mission work at the Philippines, the Philippine population is very good at getting pregnant. They have lots of big families. So family is incredibly important, and protecting your family, I think, is a huge reason to encourage vaccination, right? Particularly those older people. So once you've kind of got that established, I think it's very important then to emphasize that while you look at vaccine efficacy, and we spent some time helping people understand that its vaccine efficacy is actual proportional reduction in disease. It's not as simple as 95 out of 100 people aren't going to get the disease. But very, very importantly, you can measure vaccine efficacy in a couple ways. One, you can talk about it preventing any acquisition of disease. And that's great if you can achieve that. But perhaps more importantly is how effective the vaccine is at preventing severe disease or death, right, from COVID. Because severe disease is usually defined by CDC and the WHO as requiring supplemental oxygen, right, or hospitalization beyond that. So if you can prevent severe disease and you can prevent hospitalization, the first thing you do is take pressure off your health system, and very few people are going to then have a mortal condition, have mortality when they aren't hospitalized or require oxygen. So, and why that's important is, at least for the 3 vaccines in the US, and we have the 2 mRNA vaccines and the Janssen vaccine.
Right.
Those are essentially equivalent in their ability to prevent severe disease and death. The other very important thing to remind people, and we use the analogy of and I'll use it for you guys, of a soccer game. Okay. Mm-hmm. And so because vaccines are tested in different venues, so they're not all tested on the same playing field. So let's say you have the best soccer team known for defenders. They have a fantastic goalkeeper, and they're doing really great against a team with a fantastic offense. And the game ends up, your team has a fantastic offense, and you're playing against this wonderful defense, and the game ends up a draw. Even at penalty kicks, nobody wins. So it's 1-1. Now your team goes, another team goes, and they play against the worst defense in the league, and they crush them 3-0. And in fact, it's raining that day, and their goalkeeper can't hold on to the ball, and it goes in the net all the time. So now you're going to ask, well, which offense is better? The one team, they scored 3 goals, right? And your team only scored 1 goal. Those guys must be 3 times better. You can't even compare them, right? Because you were playing against one. The defenses were different. The weather was different. Everything was different, and that's a little bit of what happens in these clinical trials.
because a clinical trial that Pfizer did for their mRNA vaccine was in a world where the variants were just starting to appear, okay, and the
Right.
resistance was low. Now you test a vaccine, and there are a number of variants. So the playing field is very different. So what's most important is, first, you tell people, okay, you may not want to get it, but do you want your grandma to get sick from you? And they're going to go, no, I'll get this. Second, you say, look, these vaccines may be different, and I don't know the data on the Sinovac and the other WHO vaccines that aren't in the US, but my suspicion is they're all pretty effective at preventing severe disease and hospitalization. And so you say, look, yeah, on the surface they might look like they're a little different, but if you look at the prevention of what really matters, which is you dying or you ending up in the hospital, they're essentially equivalent. Okay, now you're going to face a couple other challenges, right? And you can try to adopt your vaccines to those challenges. So because of the rural areas in some of the Philippines, and I think you guys have 10,000 islands, I think I'd heard, and so, you will want to match the vaccine and its supply chain requirements to that area that you're going to go, right? So if you have a vaccine that doesn't require the Pfizer vaccine, the Moderna vaccine probably aren't the best for the rural parts of the Philippines because that cold chain, it would be broken. But some of the others, Janssen, Novavax, where those requirements aren't as severe, you can get them there. That's one thing you have a challenge about. And you're going to also have a much greater challenge than we had. We really work to keep our sites to a single vaccine because the vaccine doses will change. And I can't imagine if you have 7 different vaccines and you're trying to keep track of those in a single clinic, that's going to be really tough. So, you may say, look, your clinic, maybe even, all of Cebu. You say, okay, all of Cebu is going to be Moderna, and we're going to get all that is going to be channeled to you guys. It makes it easier for the healthcare providers when they develop their flow diagrams. We saw some errors, and we only had 3 vaccines to worry about, really only 2 platforms, because you could almost, the Moderna and Pfizer, they're different. Their dosing, second dose is a week apart, but we all know it probably doesn't matter. So you could probably mix up those and they'd probably do okay. But when you start mixing and matching 7 different vaccines, you're going to have a logistical challenge. So educate on science, tell them how important it is to family, tell them about the vaccine efficacy. What that matters is keeping you from getting really sick.
Nice. Thank you, Dr. Hitt. So that's a lot of information, even for us to process now. But there's one thing that you said, and I think it's the bridging, right? So bridging the information from the providers of information, scientists, the researchers, giving it to the patients. And my question now, so this might sound odd, or maybe it is a part of also the need to bridge. This is for Mr. Moya. Is there an app for that? So is there an app? Is there a technology, a digital solution that can actually, not only for the bridging for information to the patient, but also for other things that Dr. Hitt mentioned, supply chain, tracking the different kinds of vaccines, the flow of operations on site in a vaccination center. Mr. Moya, in your experience in Microsoft, or maybe even contact tracing, many other things in the strategies, is there an app for that? So what apps are there that can help in the pandemic response? Over to you, sir, Mr. Moya.
Thank you, Doc Albert. Bon lang po. That's actually a very interesting question that will go all over the place. But I guess the short answer is yes, there's an app for everything. And if it's not there, there is a whole ecosystem of guys who will be more than willing to jump in. So the problem is not the availability of apps. The problem is the applicability of the app, because for the apps to work, it has to be prescribed or used. Let me cite an example. Let me first cite an example on fragmentation. On the question of devolution, it's not an exclusive domain, whether you're either devolved or centralized. And proof of this are systems like Grab and Airbnb. These are highly fragmented suppliers, highly fragmented demand. but that comes together simply because there's an app that integrates the data. You know, it's more complicated than you think. For example, Airbnb, because there are currency fragmentation, there are supply fragmentations all over the world, and there are variances of those who will choose to put their supplies online, and there has to be a standards that need to be met. So ultimately, it boils down to the standards. And this addresses the fragmentation issue on devolution. We don't necessarily need to undevolve. We just need to make sure that the back-end systems flow together so that they are integrated and comes together. The problem with the system, like contact tracing, for it to be effective, it needs to be used by everyone. A certain percentage using platform X and a certain percentage using platform Y that never come together and share that information will not produce the efficacy of contact tracing. In the same manner, a local government that uses a vaccine database tracking X and LGU that uses vaccine tracking Y comes together, it's quite possible that they have duplicate data that will not probably come in, causing all those problems. So the key problem is invisibility of data. And those data need to be made visible. And it's easier than you think, because you have to nuance the visibility of data, the public health concern, the visibility of data, and the right to privacy of those who actually own that data, their public record. So you have to nuance and balance that. The state, particularly the federal state, has that authority to get that because there's a public health issue concern. So that I think even in the Data Privacy Act, that trumps the right to certain privacy because there's a public health issue. So we need to lay the framework that even if the systems, the implementation are not centralized, that at the very minimum, the data can be centralized together. The problem is we have done this before. We have done this in banks. You know, you have money in your mobile phone that can be flowed into your bank account in Bank X, Bank Y, Bank B. That ecosystem developed over a long period of time, coming together, deciding on a standard, applying those standards to individual system takes some time for it to happen. It happens in airline industries. You take one airline, you go to another country with a different airline, they have visibility of all those coming in and coming out. It takes a while to do that. We don't have that time, so that's the problem. And therefore, the state needs to come in and put in some push and some muscle to ensure that there is data integration. And systems cannot talk if institutions cannot talk. So ultimately, the institutions need to come together, sit down. Doc Carbosa actually started something similar many years back. It's called the Philippine e-health roadmap. And that laid the groundwork for something that should have been done many years ago, which should have put us in a good position to at least mitigate some of the risk. But we did not do that because there's no visibility of all that e-health system. Many of the thinking has already happened. So we just need to go back, revisit, take it down. And in fact, I think Doc Teddy made sure that it was an interagency activity. The OST had a say, DOH had a say, PGH have a say. And that document now, guess where that is? It's in a filing cabinet somewhere.
Sir Bon, while, because I'm gonna go to Dr. Teddy next, no. Pero while Doc Ted is still thinking on what he's going to say about the e-health, I noticed that the time is 9:58. Senator Risa has to move on to another legislative activity, and we are very privileged to have her with us even for an hour. But ma'am, before you leave, kasi nabanggit no, so Sir Bon mentioned, no, there is a need for the state to push. So parang I was reminded, we have a senator in the forum. Ma'am, siguro po as part of your parting words po, and we'd like to give you our thanks also for joining us. What could that push be? Yes, ma'am.
Well, I think, thank you, Dr. Albert, and I'm so sorry that I'll have to leave early. I hate to leave early, but I have to go to a hearing of the Senate Committee on Urban Planning, Housing, and Resettlement. I've been learning so much. I know I'll miss a lot having to leave early, but I've been able to take some notes from all of you, dear speakers, that I'll use in my continuing legislative work with the guidance, as usual, of Dr. Albert, and be able to consult Dr. Teddy as well. Well, I guess a large part of our work is still overseeing the implementation of the universal healthcare law. Even when the pandemic hit, my first impression was, oh my God, this pandemic is the litmus test for the implementation of the universal healthcare law. For me, it is still the Magna Carta. It's still really the mother of all of our health efforts moving forward. So thank you very, very much, Dr. Albert, Dr. Teddy, Sir Bon, Darwin, and have a good day, everyone. And to Dr. Lashanda and Dr. Hit, good night. Thank you so much, everyone. Stay healthy.
Thank you, Senator. Ingat po.
Ingat.
Right.
Ingat.
Thank you. So Senator Antiveros, that's the perfect segue already mentioned. So the UHC law is there, no? And USEC TED, isn't it that inside the UHC law there's supposed to be a requirement for data sharing already? Plus we have Sir Bon mentioned, no, even the Data Privacy Act, it does have an override for situations like a public health emergency. My question, USEC TED, why is the e-health framework not working in our favor for the pandemic response, sir?
Well, let me explain. No, some things to correct. Bon, no, the National E-Health Strategic Framework and Plan continues, but there were changes in the personality in the leadership. ICTO, which was previously under the ICT, or Information Communications Technology Office, which was under the DOST, was moved up to a cabinet level position, which is the Department of the ICT, Department of Information Communications and Technology, and they ended up doing a lot of work, a lot more work, and I don't know what happened, but the e-health strategic framework and plan, although it's still not been replaced and is still the plan for UHC implementation, continues to drudge on very slowly in terms of implementation. And then COVID-19 hit. When COVID-19 hit, we wish we had implemented the e-health strategic framework and plan, because you saw the countries that actually managed this pandemic well used a lot of their electronic medical records, a lot of their information systems in health, from the UK to Israel to the US. They used electronic medical records to be able to get people vaccinated very quickly, to get them scheduled, to tell them by email, you have an appointment and you're supposed to come or else you won't get your vaccine. So, but here in this country, we're struggling with creating master lists. We don't even have a national ID yet, although it's being started. So we're definitely late. We're not using our tools very well. In the beginning, the National Task Force was talking with the ICT, because the lead for the use of ICT in vaccine implementation and the fight against the pandemic was the ICT, is the ICT. Unfortunately, they also changed horses in the middle of the race. You know, for example, in the beginning last year, they were telling us they'll just get an off-the-shelf rack, and I was looking at Bon Moya or Microsoft's Azure, which was a fantastic vaccine administration system, that we didn't need to do that, didn't need to create that. But apparently somewhere in the hierarchy of the IT governance in the country, they decided to make their own. Luckily, we still don't have it 6 months later. And we're already in the midst of our vaccination, and still waiting for a national vaccine administration system, the DVAS, or the VIMS, the Vaccine Information Management System. It's still work in progress, and it's still got a lot of bugs. So what did the LGUs do? The LGUs got off the shelf. So some off the shelf were okay. Some are being complained of. Some LGUs are having problems with their registration system, but most of the local governments did it on their own. I mean, the autonomy of local government, and some were very successful. Some were able to vaccinate very well because of very good administration of their information system. So suffice it to say that IT is indeed a very important tool in the fight against a pandemic globally. And we saw that. I think the importance of using it for contact tracing, for vaccine administration, for projections, for modeling, the IT part of the fight against pandemic is an important tool, and we missed out on that. I think if there is something I will correct in this review of this pandemic, it's that we didn't use that to the maximum. We didn't use it to its full potential to help the country. It could have helped us do more with very good collaboration, and it could have been done with the private sector collaborating with the government. Thank you.
You said very interesting, no? Parang on the one hand, we'd like the pandemic to end. Sure, we do want it to end already. But on the other, it seems that the continuing pandemic still gives us that chance to test, no? Like you mentioned, parang it's not yet too late to test. Parang we want to finish this already, but since it's still going on, might as well let's test the systems. And the first question that was sent in by our viewers, so we have a viewer who is asking, is there still anything missing in the policy infrastructure to support digital solutions? I'd like to throw this question to Mr. Moya, Sir Bon. So what else is missing for the Philippines to support digital solutions for the pandemic? Or is there even something missing? What are your thoughts on this?
There are many levels. Sorry, that there's no quick answer and easy answer. But yes, first, data standards. Data standards need to be agreed by all stakeholders and need to
Yes.
be implemented at the pain of something. So that's the second component. There is no enforcement mechanism. So well, the ICT currently, in fairness to them, they're doing so many things at the same time, and that there is a fire. The enforcement of a data structure, of a data standard, doesn't seem to be that important at this stage. Which it is, but it doesn't seem to resonate as much as having a system that runs and tracks the vaccine. So that's part of the gap that we need to address. So I think that's the first one. Enforcement is the other one. And the other one is a structural approach, not just to institutional approach to this type of scenario. Knock on wood, likely the Philippines on a regular basis does dengue vaccine. We do what's that one on the rat urine?
Leptospirosis.
Leptospirosis.
Yes.
On a regular basis, as a tropical country, vaccine should be part of our medical public health DNA. And yet now we need to come in together, make that institutional, so that when the next COVID comes in, there is an institutional group that comes in. The good thing about the interagency task force is that it forces integration, except that the enforcement still has to go to the individual agency with the budget that has prerequisite ways of spending that money. So even if IATF says the ICT has this, the money is in DOH, and the legal liability for spending that money is in DOH, DOH will have a lot of say on that part. So institutionalizing, reviewing who is in charge. I do understand we have RITM, that really does as a regular mandate vaccine, and then you wonder why that vaccine institution isn't playing a bigger part now. Then we should muscle them up, give steroids to that institution, allowing us now to be better prepared. They can then control standards on vaccine, standards on immunization. They can prescribe it. They don't necessarily need to build it, and then have an enforcement power where LGUs who do this, who do not comply with the data standards and interoperable standards. So I think that's the critical component.
Sir Bon, I'd
can
like
I add
to segue. Yes, go.
Can I add to that? Yeah, because he said a word that I was waiting for. He said interoperability. So what has happened because of lack of IT governance is that local systems develop their own IT systems to make their own work function. So local health will do their own systems, the ILG will do their own systems, DOH did their own systems, but it is not interoperable and they're having problems. Laboratories have their own systems. So the interoperability part is the key. That's why you need to do the data standards. So if you do data standards, data nomenclature, you'll have interoperability. Because we're not interoperable, they're trying to ram down stuff to the health systems who have existing legacy systems that work, that they don't want to change, because it's working for them successfully. So I think they're seeing it wrong by trying to develop it from a mandate as the ICT. But I think the key is to just look at what's existing, put them all together, and make sure they are interoperable, which is the same idea of the National eHealth Strategic Framework and Plan. We wanted to have a health information exchange. It is the time to do the health information exchange so that everybody can submit to that information exchange or data lake, and the national government, the IATF, the NTF, can mine the data from that lake and give very good, accurate, real-time dashboards and data of what's happening in the health system.
Yusek Ted, let's ask Dr. Cobbs. So Sir Bon mentioned that we do have to have at least two things: data standards and someone to enforce these data standards so that we will have the interoperability. that probably California and Texas and New York and Delaware, they're all talking the same with Washington, D.C. Dr. Cobbs, can you tell us in the U.S. experience, who cracks the whip? If, if the state decides to use a different data standard and then Washington says, no, this is the data standard that has to be used. How is the whip? Is there a whip? Who cracks the whip? Or are there carrots, incentives? How do you do interoperability for health data over there, Dr. Cobbs?
So I'm going to actually tag my partner, Dr. John Hitt, on this one as well. I don't think that we have a national platform that we are using. I know in COVID vaccines, every state has a different vaccine repository, and they don't necessarily talk to each other. When we were going through our process of establishing in the testing environment, we would have to do opportunities where we could connect the labs with the state and with our information to ensure that that interoperability was there, but it was not a given. And so, Dr. Hitt, I'm going to ask you to talk a little bit about maybe, I don't want to misspeak, but is there in your knowledge standardized interoperability across all health information across the country?
Dr. Hitt?
Yeah. So not even close. The one of the goals of national healthcare policymakers is to set up some standards, and we've had some incentives in place to move people to use more EHRs. And what we have in this country that usually sets the standard is the Center for Medicare and Medicaid Services, which is the government, insurance primarily of older Americans. And when they set a standard, the private insurers tend to follow. And the government sets the rules and the laws, then CMS takes those and puts them into place. And then often, most of the time, the private insurers follow that, because many private insurers actually administer the plans for CMS. So that long story being said, that yes, there are some incentives in place, and there are some standards for data transfer, for interfaces and things. But no, we have a huge number of different medical records. Now, in some areas, for example, in the state of Minnesota, almost every hospital and health system is on the same electronic record. In fact, I think they all are, with just a few exceptions. And then it allows a great deal of transfer. However, there's also a separate public health system, right? So most states require you to report vaccinations, right? So, and most of the health systems have figured out how to do that from their electronic record. So they download the vaccine data to the state vaccine repository. However, those state vaccine repositories all differ. Now, in theory, they all send that data to CDC. And it actually works pretty well, and has worked for years for tracking and getting standard vaccine data to CDC. And all of us who've done this for years kind of worried that all the people getting their fingers in COVID would bugger it up, because, pediatric vaccines, typical standard vaccines, we do a pretty good job of getting that information to CDC and CDC compiling it. But then everybody and their cousins started to get involved with COVID. They were going to have the military distribute the vaccine, and all of us in vaccine world goes, oh my God, the military may be good at sending jeeps to the Middle East, but they've never done mass vaccine distribution. So, I think we generally avoided that, dodged that bullet. But we do have a national health agency and CDC that 10 years ago was an organization to be admired worldwide. It had some challenges in funding. It's too bad the senator isn't here. And it had challenges in support from the country's leadership over the last few years, and that greatly hampered our ability to respond. So if there's something that you guys have already mentioned and you could learn is you do not want to shortchange funding of public health. And many of the things that we knew needed to be repaired and improved with the Centers for Disease Control were not done under the last administration, which I think the world appreciates had a different attitude about things than our current administration. And we can leave it at that. And our current administration has unleashed CDC to do its job. The previous administration was filtering data. They were reading reports and rewriting them, and it greatly undermined public health's credibility. Now, CDC in the last 6 months has turned out tremendous valuable information that you guys could access easily. And I say CDC is now unleashed, and it's doing a good job. But we have big gaps, Dr. Albert, big gaps in having a seamless system. It's better in vaccine tracking than in a lot of health stuff, but we still have gaps.
Great. Thank you, Dr. Hitt. I like how you carefully touched on the change in U.S. administration in the past year, which could be one of the reasons why there is a resurgence in public health support in your country now. Interestingly, the Philippines is also about to enter an election year next year. Some would even say we're already inside election year, given the way our politicians are positioning. And that's my way of saying this particular discussion, and that's my segue to the next question, this particular discussion we're having now is an opportunity for us to influence what the politicians will be saying as their platforms for government, as their campaign pitches, whether at the national or local level here in the Philippines. My next question is to ask, is for Mr. Moya, Sir Bon. If you had a chance to influence what a national government politician or a local government politician will be saying insofar as operationalization of vaccine manufacturing is concerned, of course, it's going to be technical the way we discuss it now, but I'm sure there are technical staff, writers among the campaign staff of national or local officials. What would be your tips? What will be needed to address the systems and operationalization of standards at the LGU level and maybe at the national level too, if we eventually go to vaccine manufacturing? This actually came in as a question. Sir Bon.
Well, thank you. Just Bon, please. I'm 27 years old. Just 3 quick points. I think the first one, we need to clearly set and publish the standards. Get everyone together, set it up, and publish it, all right? And then the second component is to actually enforce that. And there are 2 ways to enforce it, by coercion and by incentive. Let me cite a very practical way that DICT is currently doing it. They actually have an EBPLS system, a business process and licensing system. They built it, they provide it for free for LGUs, right? So that they can use it and derive the benefit, and then DICT absorbs the tab. It's cloud-based and it's easy for them to. So that's one way of doing it. We have something you can use that makes it easy. You don't need to think about it. Just make sure you implement it. Alternately, because there's a certain degree of autonomy of the LGU, if they don't want to use the system provided by DICT, at the very minimum, whoever they will put in must comply with the data standards integration as a requirement. And that enforcement can happen with money. Public funds are highly tracked items. So for them to legitimately use public funds, you have to put a criteria in the disbursement of that public funds and saying, if you're buying this system, it needs to comply with this policy, which is the data integration. Absent that, you cannot disburse. Then everyone follows. Then it becomes visible to everyone. So I think those 2. I think I'm not a health expert, but it seems like to me, healthcare is best achieved by people closest to the ground, and therefore makes that devolution very practical and very pragmatic. Then the next step is that if we need to do the front facing, we now need to empower the front facing guys with so many back end systems that then the national government can then create, curate, build, and then operationalize.
Great, thank you, Bon. So that's a very interesting way of, and look at the time; it's already 10:19. So I'm pretty sure the beauty of Asia Society Philippines webinars like this one. It's not a webinar; it's more of a conversation. Is that this gets archived and this gets played even after we do this live. So Bon mentioned the front end and the back end. So I'd like to thank, from the front end, I'd like to thank all of our speakers. We already saw the senator leave, but with good reason, because she has been taking notes and she is going to attend a different hearing already. So thank you, Senator Risa Ontiveros. And then, of course, thank you to those who are still here with us, Dr. Ted Herbosa, who is a very busy gentleman. I'm pretty sure after this particular conversation, he'll probably be in another meeting, or if not in a meeting, in a site inspection or something. He is with the National Task Force Against COVID-19. Thank you, Dr. Urbosa. Thank you, Richard Bon Moya. Thank you, Bon, for your insights. You may not be a health expert in name, in title, but the fact that you are pushing for health exchanges, you already are helping very much in public health. We will give you that, definitely. You don't need to have an MD. You don't need to be like Dr. Urbosa, me, or Dr. Lashonda Cobbs, or Dr. John Hitt. Thank you, Dr. Cobbs. Thank you so much. We know it's a evening over there. Thank you for your time, for being with us and lending us your insights. Thank you, Dr. John Hitt. One of the very things that are hard to piece together is to how to bring complex information and communicate it to the public. Thank you for helping us out. And from the front end now, I'd like to go to the back end. Over back to you, Joy, for us to close this very fruitful conversation. Back to you, Joy.
Yes, thank you so much. Again, I will just repeat, Doc Ted, salamat sa oras. Bon, for all the insights, we learned a lot. And for our partner, the Optum and UnitedHealth Group, represented here by Dr. Hitt and Dr. Lashonda, thank you for joining us for the past 3 episodes of this PPP that we had. And I would also like to mention that Attorney Darwin Mariano had a big hand in putting all of us together. So, Attorney Mariano, as always, grateful for your support. The Optum United Health Group, but most especially Doc Albert. Again, kudos to your always amazing facilitation and hosting. I don't think the conversations will end here. And I know, Bon, we had this talk about a coalition. Let's think about that and let's proceed with that so that in the future pandemics and the future things that we need to support will happen. And with that, mula po sa Asia Society Philippines and my team, Kit, Pat, Pam, and Amy, thank you everyone and have a good morning.
Thank you very
Salamat,
much.
thank you.
Maraming salamat. Thank you po.
Bye-bye po.